acute pancreatitis patients, every patient should perform CT scan. And ERCP, MRCP, and abdominal plain view, we can selectively choose these this picture is a view of acute pancreatitis. So this CT scan, you can see this is pancreas, tail, body, and the pancreas head. These are hypodense loci. Hypodense. This may be the necrosis of the pancreas body. The normal pancreas is like this. This is full of blood supply. But the necrotic tissue, there are no blood supply. It's gallbladder edema. So this edema of the pancreas, no hypodense.
Actually, the edema of the gallbladder, you said, was related to pancreatitis?
Yes, related to the pancreatitis.
What caused that? What caused it?
What caused?
I mean, how did it?
Maybe stimulation by the stimulated by the pancreatic juice.
So every time if a person has pancreatitis, he would have gallbladder edema? If a person has pancreatitis, every time he would have gallbladder edema?
In what patient?
Pancreatitis.
In patient, many people that have gallbladder edema. So it is very edema of the pancreas, and the digestive of the omentum and the lipid surround the kidney, the lipid. So also have edema of the gallbladder. This is a severe. It's a severe pancreatitis. So almost all the pancreas were necrotic. Only a little normal pancreatic tissue. So all have hypodense. Almost all the pancreas were digested by itself. So it's severe. Also we can see it's edema of the gallbladder. So the fluid collection, the collection of the fluid exudate from the pancreas is the pelvic cavity. We also can see fluid. And this is from one patient. This pancreas is squeezed, so the pancreas was necrosis, and this collection, this is kidney, this collection, a lot of collection. So we'll talk about the complication. At previously slide, we talked about the pancreatitis. It is not only a local disease, but also a systemic disease. So in local complication, we can see the pancreatic necrosis. Earlier, the necrosis is sterile, no infection. So the pancreatic necrosis will develop into pseudocyst, pancreatic pseudocyst. If the necrotic tissue necrotic tissue is infected by bacteria, so it will infect pancreatic necrosis. Because the necrotic tissue is a good medium of the bacteria, so it is very easy. It's very easy to be infected by bacteria. So if the necrotic tissue was has infection, this tissue will develop into pancreatic abscess. So in local complication, we will have necrosis and pseudocyst and abscess. We have to talk about the acute pancreatic pseudocyst. The peripancreatic fluid collections occurs in 10 to 20% of the patients. These fluid collections of the necrotic tissue we are surrounded by fibrous tissue or granular tissue. This collection, we call it pseudocyst. So this pseudocyst have no epithelium. So we just call it pseudo. It's not a real cyst. Just in fact, it is a collection. It's a fluid came from the pancreas. As a fluid. So the fluid was surrounded by fibrous tissue or granular tissue. We can diagnose this from the ultrasound or CT scanning.
So we have a area of necrosis, and around that area we have collection of fibrous tissue and granular tissue. Only that thing is called pseudocyst.
If the patient is suffering appendicitis, we also have a collection of surrounded by fibrous tissue or granular tissue, but we don't call it pseudocyst. Pseudocyst just means in pancreatitis, we call it pseudocyst. Because the pseudocyst is the fluid from the pancreas is very dangerous. It's content include pancreatic juice maybe. So it is dangerous. So we call it pseudocyst. But in other diseases we don't call it pseudocyst.
So what is the difference in edema around the necrotic area?
Edema,
yeah.
Difference is the edema.
Yeah.
Edema and the pseudocyst. In the early phase, maybe edema and collection, but in later phase, the collection will surrounded by fibrous tissue and granular tissue. So it was surrounded by the tissue. We call it pseudocyst. So the pseudocyst, the fluid in the pseudocyst can be absorbed by itself. So it's a pseudocyst. You can see this is pancreas, maybe edema, maybe necrotic, and a lot of fluid exudate, and surrounded by the fibrous tissue or granular tissue or other organ, maybe stomach, maybe transverse colon, and maybe granular tissue. So was surrounded by other tissue. So we call it pseudocyst. It's a pseudocyst discovered by CT scanning. So here, in early phase, we can call it necrotic tissue. if in later phase, the necrotic tissue or the fluid was surrounded by tissues and surrounded around or and cyst, we call it pseudocyst. We also have talked about in clinical acute pancreatitis can be divided into mild or severe. So, what is severe acute pancreatitis? We from the definition, and in pathologically, the pancreatitis in pancreas have hemorrhages, have necrosis, maybe have pseudocyst, If in local complication, have necrosis, abscess, or pseudocyst, we can see it is severe acute pancreatitis. And secondly, if the patient have systemic change, just as symptoms of MODS, we also call it severe acute pancreatitis, or both. If both have MODS and pancreas necrosis, we also call it severe. It's severe pancreatitis. So, about the clinical classification, we can divide it into mild and severe. In this way, we can general evaluation or local evaluation and MODS evaluation. There are a lot of methods. A lot of doctors will evaluate the local and the MODS evaluation. So, as to acute pancreatitis patient, we should evaluate the local change. We also have to evaluate the systemic change. The clinical manifestation of the severe acute pancreatitis. We also have abdominal pain and severe distension and vomiting and various obvious tenderness, newborn tenderness, and muscular regard. After that, we will have two very special signs and fraternal or coolant signs. If the patient have signs of fraternal or the coolant, we can call it severe acute pancreatitis. SAP. If the patient have MODS and shock, hypo pressure is a very low pressure, blood pressure, we also call severe. And in local, we can use CT. Evaluation. In CT evaluation, if it has hypodensity or invasive outside of pancreas or a lot of fluid activated from the pancreas, we also call it severe. If the Apache value is less than 8. So in acute pancreatitis patients, CT scanning is very important. CT scanning can find necrosis, can find pseudocyst and abscess. So if there are necrosis and abscess and pseudocyst, we call this patient is severe acute pancreatitis. After that, we should evaluate the multiple organ dysfunction, just as cardiac function. If the patient has very quick pulse and tachycardia and tachypnea and have very low blood pressure, we make the cardiac dysfunction. And about the pulmonary dysfunction, if the oxygen pressure is very low, lower than 60 millimeter mercury, and maybe have some tachypnea, and with symptoms of ARDS. We got a pulmonary dysfunction. Also, in severe acute pancreatitis, the patient will have elevated BUM and creatinine. Maybe the urine volume is very little. And in liver function, the patient will present with jaundice and elevated ALT. And in digestive dysfunction, we can find a very obvious distension and GI bleeding. It is caused by stress. And in endocrine functions, maybe the glucose is very high. The glucose is very high. It is more than 11.1 millimoles per liter. And the patient will also have coagulation disorder and nervous disorder. Will have unclear consciousness, paralytic brain disease, called is paralytic brain disease. So in severe acute pancreatitis, every organ and system will affect it. So we must evaluate every organ, include heart, lung, liver, and gastric, and kidney, and like every organ will have this organ. So we should evaluate. If the patient accompanied with MODS, so the mortality is very high. Maybe as high as 20%. Okay, have a break. Okay, let's begin. Continue our last one. And just now we talked about the MODS in severe acute pancreatitis patients. So next we'll talk about the stage of the severe acute pancreatitis. We all in early stage, the pancreatitis have no infection. So this stage we call acute response stage, mostly within 2 weeks. And in this stage, at this stage we call acute response stage just third stage, no infection, mainly in systemic inflammatory response syndrome. So we should focus on the MODS, the shock, maybe ARDS and renal failure, essential. And the second stage is after 2 weeks, and within 2 months, this patient will suffer from infection. So we call it systemic infection. So about the treatment, we should focus on the acute response stage and don't let the patient infect with bacteria. Don't remove to the infection stage. And the last stage is post-infection stage is after 2 or 3 months. This patient and recover from the infection. So also maybe recover from several times of operation. And we also found abscess or the fistula. Sometimes maybe the blood vessel rupture, maybe. And the treatment. As we know, in mild acute pancreatitis or in the early stage of the severe acute pancreatitis, we almost do the non-operative therapy. So what can we do? Use medicine in acute response stage. In almost all the mild acute pancreatitis, medicine is always effective. This patient can recover from the convertive therapy. But in severe acute pancreatitis, in the early stage, in acute response stage, we also use medicine. We also use medicine. But we should be very careful about these patients, because of these patients may be developed into MODS. So these patients, we should be very careful. We should observe in ICU, and evaluate of the every organ of the severe acute pancreatitis, mainly the renal failure, the pulmonary dysfunction, and cardiac dysfunction, and GI bleeding, and we should observe very carefully. And after that, we should give this patient fasting the patient and nasogastric suction. We do this, maybe it's reduce the pancreatic secretion. And about the fasting time, maybe 7 days is okay. 7 days is okay. And we also use other medicine to reduce the pancreatic secretion, just like Losec, the antacid, and Losec, and ranitidine. And sometimes we also use 5-FU, and mainly we use somatostatin analog. Somatostatin analog. We can repress, we inhibit the pancreatic secretion. And we also can use anti-protease. And after use this medicine, we also use support treatment. We should fluid replacement and nutritional support, because of all these acute pancreatitis patients will fasting. So we will give the nutrition from blood vessel. So TPM will give this patient. And the glucose, include glucose, lipid, amino acid. Sometimes we should give protein, albumin, and plasma, like that. And because the acute pancreatitis patient will feel severe pain, severe abdominal pain. So we also can use analgesic. If the patient pain is clear, is caused by acute pancreatitis, we can use analgesic. In acute response stage, also this patient have no infection, but usually we'll give antibiotics, just prevent infection. Because after infection, the mortality and the morbidity of the severe SAP patient is very high. So in early stage, we will use antibiotics to prevent infection. And after that, in China, we also have traditional Chinese medicines to recover the bone function, just the GI function. In order to the eating the patient can eating something. And at last we also can use abdominal lavage. So every patient, either this patient is mild or this patient is severe. In early stage, we almost all use conservative treatment. But what time we should do operation?
Excuse me, Professor. In non-surgical treatment, can we do dialysis of the patient?
Dialysis.
Yeah.
Yes. A lot of people, we can do dialysis. Just remove the inflammatory factors to help recover.
So, I mean, which would be much better, dialysis or this? Because we have to go through such a long process, right? And on the other hand, if we do dialysis, we can save a lot of time. What do you think is, I mean, which is the better one?
Which is better?
Yeah.
Accept this kind of treatment, we can do dialysis, CRRT.
Usually, dialysis is acute this panic stage. As a patient, usually with dialysis discharge, and the hypocrisy is older. It is maybe advanced stage now. Just a professor with infection, severe infection, cardiac abscess, usual operation. The only we do a dialysis is really useful, I think.
Thank you.
So what condition we should do operation? What time we can do operation? Just 4 conditions we should do operation. The first, all know the most common reason in China is the biliary disease. So if the patient have biliary obstruction just mean in CBD stone, we can do emergency operation. If the pancreatitis just induced by pancreatitis or gallbladder stone, we will not do operation. We will not do emergency operation. But if the biliary obstruction, we can do operation emergency. And secondly, if the patient have pancreatic infection, just means pancreatic abscess formation. From the pancreatic abscess, the patient will have very high fever. We can do operation. Third, if the shock cannot be reversed and multiple organ destroyed. So in this condition, we can do operation. Just mean impermanent acute pancreatitis, we can do operation because the thirst is very severe. Even if if very low blood pressure, we also should do operation. And the last one, if undetermined diagnosis, need to laparotomy. Just mean a lot of differentiation disease is a lot of acute abdomen. We cannot do well differentiation, just as population of GI. And maybe strangulator obstruction, bone structure, we cannot differentiate it. So this time we cannot rule out the GI population. So we can do operation. So this time, these 4 conditions, we can do operation. This is the scheme of the principle of the pancreatitis. So if the patient is mild acute pancreatitis, we always use conservative therapy, just use medicine. And if this patient is severe, so if this patient suffers from biliary, have obstructive, we can do urgent operation or ERCP. Take out the stones, and remove the cause of the acute pancreatitis. And if this is non-obstructive, just means gallbladder stone. So we don't need to urgent operation. We just conservative therapy. But after recover of the pancreatitis, we should do cholecystectomy to prevent the next episode of pancreatitis. And the severe acute pancreatitis is not induced by biliary. It's other cause, other reasons, just hyperlipidemia, hypercalcemia, and ischemia, and like that. It's not not non-biliary. So if this patient have no infection, we just continue conservative therapy. And if the patient have infection, we will do elective operation. This is the principle of the
in the obstructive segment, you said that we can do ERCP, but as we read earlier, ERCP is a etiologic factor for pancreatitis. Now, it will aggravate the severe acute pancreatitis.
No, not all the ERCP can induce the pancreatitis is a complication of the ERCP. Pancreatitis is one complication of the ERCP, but not each ERCP can induce pancreatitis.
If suppose a case happens that you did an ERCP and then the patient's pancreatitis, instead of recovering, it went into a further aggressive phase, then
Then they'll do the operation.
no operation, but you have performed one procedure. Immediately you can't just.
I mean, is it possible to aggravate the situation by doing ERCP? Can we make the patient more worse by doing ERCP in pancreatitis?
More severe?
Yeah, more
Yeah.
severe.
No, ERCP is resolve the stone, is take out the stone. So the cause of the pancreas is removed. So it's help to treat the pancreatitis. Will not